So today I am going to do part 2 of the interpretation of the 24-hour comprehensive urine hormone profile. That's a lot of words. And what I wanted to do to begin with is to just go over the review of part 1 for those of you who didn't attend, and for those of you who did, it's been about a month or so. So we ended with a review of part 1 by saying that there were certain requirements for accurate urine steroid profiling. And we know that there are many, many peer-reviewed articles that detail 24-hour urine with GCMS, gas chromatography, and mass spectrometry. That's well known. That's established for decades. But there are no independent studies that are comparing and contrasting 24-hour urine and dried urine. I'm calling that DU, which is a spot sampling of urine. And so what I was saying in the first part is that in the absence of independently published methods and data, and given the small, limited volume of urine that you get with dried urine samples for this type of analysis, which needs a lot of urine, by the way, it is unclear how quantitation of certain analytes, such as these hormones, can be credibly accomplished and reproduced. It's the reproducibility as well that is important. And so there's a real question if you can do that with confidence. And in fact, the dried urine paradigm is arguably outside acceptable scientific standards. And that's not just me saying it. That is what a lot of people have been saying for a while. And so what I ended with in part 1 is that if you want to do the most complete assessment of hormone function, what would be the ideal combination of tests? Well, with urine, it would be the 24-hour hormone profile, because you're getting both the free and the metabolite fractions. Saliva, if you're looking at adrenal function, you want the 4-point cortisol. It also gives you DHEA. And of course, as you know, for those who do our saliva analysis, it will give you a quick thumbnail look at some of the sex hormones, which is fine. Doesn't go into great detail. For that, you need urine. And the last thing would be serum. And serum, if you're looking for thyroid panels, for any number of different things that you would do in a classic blood workup, a CBC, a serum iron, a total iron binding capacity, etc., etc. So each has a set of clinical strengths, has limitations, and sometimes you need a combination of these testing methodologies if it's appropriate. So sometimes you want to do urine and serum. You want to do all three. It all depends.
Hey,
So,
Dr. Gonshor,
yes.
would you mind if I interrupted you for just a moment?
Sure, Reed.
Hey, thanks very much. Well, it's always so good to see you on these calls, where we keep the education coming. And there's new stuff all the time. And we're continually revising our point of view based on the science. I've been really enjoying that Science Matters the show that you and I do every other week. That's been great. But I want to make sure we clarify for listeners today that we're talking here about urinary hormone testing, and that some of the things you might say about that might not apply to some of the other things we look at in urine.
Absolutely. Yeah.
And so I just want to make sure that's clear, that if you haven't covered it, we cover it.
No, I think you're absolutely right. And I am going to make that point very, very soon, because I think one needs to separate the use of dried urine, which is a wonderful modality for other types of analytes. No question about it. It's been a wonderful way to be able to do it. And we use it for our metabolic wellness profile. So there's no doubt that it is important, but not when it comes to hormones. And we're going to go into that right now. And so we're going to be looking at these 4 areas: the estrogens, the androgens, progesterone, or what we use to look for progesterone in urine, and of course the adrenal corticosteroids and corticosterones. And we'll go into all of that in just a moment. There are many ways that one can look at all of this, and this is a very busy slide, which for those who are going to be using the test that's coming out in right after Labor Day, you're going to see that one looks at all of these different pathways and the enzymatic steps that go through it, a lot of information. And we can decorticate or go through all of these in detail, not just today, but as we move on in all of this. And you'll see that in the pink, you really have the sex hormones, the pink or red, and in blue, the adrenal or the corticosteroid hormones. And when you're going to be getting a profile, which you're going to be seeing, it's going to be in this kind of form. It's a couple of pages which show all the relevant analytes, hormonal analytes, and the various ratios, telling you what is the optimal range, et cetera, et cetera. So let's look at the estrogens, and you'll notice that for these different groupings, I put together these slides to make it a lot easier to try to understand what's going on. And you can see that all of the hormones come from cholesterol and go through a series of steps, which in this case brings you to the primary estrogen hormones, estrone E1, estradiol E2, and estriol E3, which we'll be going through in just a few moments. And from these primary hormones, we get to their metabolites, one of the main reasons for doing urinary analysis, because you see the metabolites. And so we're going to be going through the metabolites as well in all of their steps and giving you the reasons why they're important. Specifically here, you see, because the metabolites are able to bring you to a point where you're able to break down the metabolites to a point where they are totally protective, where there's no ongoing effect systemically, or you can run into some real problems with certain metabolites, which can cause a lot of DNA damage and mutation, leading in some cases to various forms of cancer. And we'll go into that in much more detail. Why are estrogens important? Well, the functioning of estrogens is not just as the female sex hormone development, which we all know about, and the maintenance of secondary sex characteristics, but also for a number of critical functions systemically. Calcium hemostasis. You need calcium to be at an optimal level and in balance, because that will decrease what is normally seen when you have low calcium, which is bone resorption. And the acceleration with a calcium homeostatic level, you accelerate bone growth and you close the ends of the bones when they're forming. That's epiphyseal closure. So you need good calcium balance for that. And the estrogens are extremely important for that kind of balance of the control of postmenopausal osteoporosis, because postmenopausal women quite often will develop very fragile bones, leading to classic osteoporotic problems. You see the hunched over old woman as a classic example of that. That's what you try to avoid. And estrogens are important in increasing all of the plasma proteins, which are important in bonding with all of the different hormones, the corticosteroid globulins, the thyroid binding globulins, and of course the sex hormone binding globulins, because most hormones, when they're in blood, are bound up with other proteins. And that's where the estrogens are very important. If you decrease estrogen levels, of course, the opposite happens. You lose bone minerals, you can get a lot of stress fractures, especially in older women, and that postmenopausal osteoporosis. And Reed was mentioning that you need to be aware that dried urine is used very effectively for an awful lot of analytes, which we do, and FDN knows that in utilizing the metabolic wellness profile, which Fluids IQ offers. But when it comes to hormones, what you need to understand is that they are pulsatile. They are changing by the second, by the minute, by the hour. And here is a classic example, and I could spend all day showing you the hundreds and hundreds of studies that deal with this, and they look at the rhythms of the various hormones, in this case, free estradiol during the menstrual cycle. And what are you looking at here? Well, this particular study looks at two types of cycling: diurnal, which you see with the dotted lines, which is what happens over a biological 24-hour rhythmic cycle, or, which is actually extremely important for the rest of this lecture, the ultradian rhythm. And what does that mean? That is what you see here as the oscillating full line, and that is what's going on every hour of the day. And you'll see here in this study, the quote that says the study of estrogens requires a full appreciation of its oscillatory dynamics. That means it's oscillating, it's pulsating. And the value of evaluating a person's estrogen level, which was the reason for this study, based on just a single or just a few time points, is quite limited. So if you were to do dried urine with 4 time points, that's very limited, because you're going to be picking up levels of the estrogens here, for example, which may bear no resemblance to what is going on for the average for that person. So that's extremely important. So going back to this diagram that we showed you, let's take a look at the primary estrogen hormones. And the classics are the following. And by the way, on the top, you're going to see what we show on the actual graphs of the report. And so you have estrone, E1, and estrone E1 for women who are on HRT, which is hormone replacement therapy. So E1 has a certain reference range, and quantitatively in urine, it's the most significant estrogen. But in reality, when you're looking at its clinical effects, it has a lot less estrogenic effect than E2. And that's why quite often you'll know we test for estradiol when you're looking at what's going on in a pre-menopausal state. But E1, the one we're looking at here, is the major hormone after menopause. And its major function is that it's an estrogen reservoir. And when you need more E2, you can convert E1 into E2. However, when we take a look at what goes on with precursors, if you look at the left, you'll notice that androstenedione, which is a precursor, only about 1 or 7% of that precursor is actually converted to E1 that you pick up in urine. So the conversion of androstenedione normally takes place in peripheral tissues. Which type of tissues? Mostly fat or adipose tissues. And therefore, why is it important to know that? Because you can get greater E1 levels in obese postmenopausal women. So if you're going to be looking at a higher than normal E1 level, one of the first things you're going to want to look at is this a postmenopausal woman? And is she obese? Because that'll give you an idea why that E1 is higher. And again, today I'm giving you just a quick overview. It's like a bus tour of all of this to give you just a foundational understanding. And I just want to let you know that we will be giving you a lot of case studies. We'll be doing them both in audio, video, as well as in a manual, in a resource manual that you'll be able to look at in order to understand what's going on. E2, estradiol, the well-known premenopausal estrogen, is the most active one premenopause, secreted by the ovaries. Now, E2, which quite often has been given as an oral hormonal replacement therapy, is converted to E1 in the small intestine. And you need to understand that in this mode, for various reasons, which we'll go into, it can increase the risk of stroke, which is one of the reasons why you see more and more often today that E2 and the other estrogens are given in a topical form, because there's less risk of stroke. E1 and E2 are inactivated in the liver in both phase 1 and phase 2 of a liver function by hydroxylating it and conjugating it. When you look at urinary E1 levels they are generally 2 to 6 times that of the E2, because remember, E1 is the reservoir. And one of the things that we offer in this particular type of report is to look at what's called the potent estrogen ratio. That is E1 to an E2 ratio. And normally they're relatively in equilibrium with the subsequent metabolism of E1 being important, but there are changes that take place. You can have a high ratio. If you have a high ratio, that indicates that there is an E1 buildup, normally because there's inadequate E1 detoxification in the liver. If the ratio is the other way and it's less than 1, what it normally tells you, interestingly enough, is that there's a urine contamination from what? From exogenously applied E2. When you're topically applying estradiol near the area of the vagina or the labia, if it gets too close, the urine will pick up some of that very, very closely applied topical E2, and that will increase the E2, meaning because it's the denominator here on the ratio, that the ratio is going to go down below 1. Now, we do know that estradiol, as I told you, converts to E1, and there's a small amount of E1 conversion to E2. E2 has anywhere from 1 to 5 times the biological potency of E1 when it's in the system, and E2 circulates at somewhere between 1.5 to 4 times the concentration of E1 in premenopausal non-pregnant women in the blood. But when you get into the urine, as I said, E1 is at a higher level. The third of the 3 estrogens is estradiol, and estradiol is the most prevalent estrogen in pregnancy, and it comes mostly from the placenta. It is a weaker estrogen than either E1 or E2, and is considered the protective estrogen. Why? Because it binds to a receptor called the ER beta receptor. Why is that important? Because by that binding, it increases the cell's differentiation and it decreases the cell proliferation. And if you think about it, if you decrease proliferation of a cell, that decreases the possibility of mutation and any kind of malignant change. We know there are large amounts of estriol receptors in the vaginal tissue, of course, because it's during pregnancy, and it is a metabolic end product of estrogen metabolism. Most estradiol, like everything else, is converted from estrone in the liver when a female goes into a pregnancy state. One of the most important things that you see in any way of looking at estrogens, and when you get a report, is to look at what's called total estrogens. And that is looking at E1 plus E2 plus E3. Why do we do that? Well, we know that in younger adults, E2 is the primary estrogen. But with aging, especially when you go postmenopausal, E1 becomes the primary estrogen. So if you're going to be measuring only one of them, let's say E2, it's really not advisable. If you're trying to determine when pre or postmenopausal women are going to need estrogen therapy, because it turns out that many aging women with estrogen dominance or elevated estrogens may have that in the face of very low E2 levels. So you can get very confused. That's why it is important to assess not just each one of the estrogens, but the total sum and their metabolites, which we're going to be going through in a few moments. So the last word then on this total sum, the high or out of range levels of this sum, often seen with oral, sublingual, or estrogen supplements. And these high levels are also seen in pregnancy and when there's urine contamination, as I mentioned earlier, from vaginally or labally applied supplemental estrogens. There is one other ratio which is important, and that is looking at the estrogen ratio, or ER, that's looking at E3 relative to the sum of E1 and E2. Why do we do that? There's an important reason. You want the ratio of this, what we call the inert or safe estriol, E3, and look at that to the potentially toxic urinary estrogens, especially their metabolites. And from that, you are able, with this ratio, to have an index of breast cancer risk. Because if E3 is greater than 1, meaning there's more E3, then there's a greater survival rate after breast cancer and a decreased risk of developing breast cancer in the first place. And this ratio, of course, declines after entering menopause simply because you get a higher amount of E1 and that decreases the ratio. I'm not going to go into the whole area of bias, which is a HRT formulation that we will do when we do case studies. And the one other ratio is the one that you see for women who are on hormone replacement therapy, HRT, and it is the E1 and E2 ratio. The normal range is normally associated with alleviation from climacteric symptoms without causing symptoms of estrogen dominance. Now, what does that mean? Climacteric symptoms are those symptoms which gradually are changing with ovarian function. They start after menopause and continue thereafter. So a lot of women will have sleep disturbances, mood changes, sexual problems, etc. Those are called climacteric symptoms. And one of the things that you want to do is to alleviate that. And so when you have E1 and E2 in a very optimal range, that means that you have very little of these climacteric symptoms. We've looked at the primary hormones very quickly. Let's look at the metabolic areas, the metabolic state of these estrogen hormones, looking at the protective as well as the more carcinogenic metabolites. And why do we look at them? Well, urinary hormone testing often provides a more in-depth clinical picture since it is measuring hormone metabolites, which you don't pick up with any of the other modalities of testing. And metabolites indicate how the primary hormones are affected. By what? By enzymes and cofactors, which are involved with anything from hormone synthesis right through to hormone elimination. And the metabolites reveal how the body is breaking down the key hormones like estrogens, progestogens, androgens, cortisol, etc. So it's very, very important. And so why are we using it? Because there's been a recent focus on estrogen metabolism and the hormone-driven cancer risk because of these metabolites. So there's increasing evidence that the amount of estrogen produced and how it's metabolized has significant implications for a cancer risk, breast in women, prostate in men. So when would you do it? You do it when you have symptoms of adrenal dysfunction, especially in the face of normal saliva cortisol levels. If you have hormone imbalance, if you're suffering from PCOS, which is polycystic ovarian syndrome, and you have acne, excess facial hair, etc., you'd say, wait a minute, let me look at the metabolites. If you're in menopause and you're actually set to begin HRT, you would want to know, is there a problem with the metabolites? So some of these metabolites, which we call the phase 1 metabolites, are 2-OHE1 and 16-alpha OHE1. 2-OHE1 is the most abundant of the E1 metabolites. 16-alpha plays an important role in maintaining bone density. And so when it's too low, that increases, as I mentioned earlier, the risk of osteopenia and osteoporosis. Now, 2-OHE1, unlike the 16-alpha, is considered the good metabolite. it's restorative. And because it has a weak binding to estrogen receptors, it really is very protective and doesn't create risks of cancer or other problems. 16-OH is in a different ballpark and is giving you increased levels of carcinogenesis and the osteoporosis, etc. And so one of the things that is offered in this report is a ratio of 2-OH to 16-alpha-OHE1. And the balance in this case is between the protective and the carcinogenic phase 1 metabolites. What we do prefer is a ratio of greater than 2. You'll notice up here the green areas between 2 and 7. That is considered quite healthy. A ratio of less than 2 increases the risk of developing estrogen-related breast cancer, as well as other things like rheumatoid arthritis, systemic lupus, erythematosus, etc. A ratio of greater than 4.5, even if you're still in the optimal level, you need to start thinking of the increase of osteopenia, especially when actual 16-alpha is actually at a very low level. I know that's a lot of information, but that ratio is important. The third of the 3 phase 1 metabolites is the problematic one. It is 4-OHE1. It is the free radical generator, highly estrogenic, and levels like the other hydroxylated E1 metabolites is significant only in premenopausal women or those postmenopausal women who are taking HRT. And the ranking, when you look at the carcinogenic problems, goes from 4-OH to the 2-OH in the E1, meaning estrione, as opposed to the 4-OH and 2-OH, which are much less carcinogenic. So high levels of the enzymes producing 4-OH, which are found in both benign and malignant breast tumors, as well as prostate, ovarian, and endometrial cancers. So there are high levels of the enzyme in all of these cancers. However, there is a phase 2 in the liver, which is going to methylate these particular hydroxylated metabolites, which is good because both the 2 and the 4-methoxyestrone E1s, which are metabolized in the second phase in the liver, they show balance between 1 and 2 phases in the liver detoxification. So if you've got a good balance of 2 and 4 meth E1, that is a good sign. By the way, the optimal ratio of the 2 meth and the 2 hydroxy E1, those two together, should be about 50% of the total of E1. There are estrogens in males, by the way. Estrogens are an important part of normal male hormone function and balance because it contributes, as I mentioned earlier, to bone density, to libido, cognition, let alone cardiovascular health. But the levels of these estrogens are extremely small. We normally talk in women in the micrograms per mil. For males, it's in the picograms, so it's 1,000 times less, but it's still there. So estrogens in men can be evaluated relative to testosterone levels, and in the 24-hour urine, you have a ratio that you can have of testosterone to the total E1, E2, E through sum, which I mentioned earlier. That ratio should be greater than 4. In other words, in a man, the testosterone should be a lot greater. If it's a lower ratio, that means that testosterone is aromatizing, which is a way in which testosterone can form estrogen. And we'll go into that in a little while. And you can look at it over here and see that testosterone can go through what's called an aromatization enzymatic pathway to give you the various types of estrogens. Let's look at the androgens for a few moments, both the primary hormones and the metabolites. Like all hormones, starts with cholesterol, goes through pregnenolone, which has been called the mother hormone, and then it goes through the various stages for androgens, including DHEA, which I'll discuss in just a moment, and then moving into testosterone. And here is the aromatase, the enzymatic pathways of both testosterone and its precursor, androstenedione, which, there you go, can create estrogens. So androgens can create estrogens, and they also have a whole number of metabolites, which we'll go into in just a few moments. But let's look at testosterone first of all. Well, testosterone is the foremost anabolic androgen in males and in females. It declines in age in both males and females. And testosterone in urine, unlike a lot of other hormones, correlates very well with the free testosterone in plasma. In many females who are in testosterone replacement therapy for various reasons, you can actually get relatively high levels of testosterone. So it's something that you want to look at not only in males, but in females. Here again, ladies and gentlemen, we get into the issue of the pulsatile nature of hormones, the reasons why you need to average out with something like 24-hour. Look at this. In testosterone, in young males, you have extremely high pulsatile levels during the day. Testosterone levels can fluctuate, peaking 8 o'clock in the morning. In this particular study, there are hundreds of these studies. And then it diminishes through the day, reaches its lowest level sometime around 8 p.m. in the evening, then climbs during the night. And there are peaks and valleys, which are very, very large for men, 40 and younger, less in older men, but they're there. So a 40-year-old, the morning reading can be 200 points higher than in the evening. So if you're going to get someone doing point analysis, be it dried urine, whatever it is, and you're going to find a point here, a point there, etc., I would dissuade you from thinking that the average is going to let you know what's really going on. And so here is one study going back 30 years ago and saying the interpretation of results of hormone measurements requires a recognition of the biological daytime and day-to-day changes of hormones. You cannot rely with pulsatile hormones on point testing. It just is not reliable. So let's look at the metabolites. The first metabolite, which is very important, is DHT, dihydrotestosterone. DHT is produced from testosterone, primarily in the peripheral tissues, and in obese males, especially with central abdominal obesity, it tends to produce even more DHT than in normal males. So that's something you'd want to look at when you have a male with a very, very large abdominal area of fat. It is significant to males who are receiving testosterone replacement therapy. It's one of the ways of knowing if you're giving them too much. And that's important because that promotes cell growth, and it's a potential role in both prostate hyperplasia and, even worse, in prostatic cancer, both intra and malignant prostatic cancer that is metastasized. And one of the other reasons it's important is that it tells you something about the enzyme that it is being formed from, and that is 5-alpha reductase, which we're going to have a lot more to say about in a few minutes. It's the best indicator of 5-alpha reductase, except for the ratio of some cortisol metabolites, which I'm going to talk about in a minute. But it is a very good way of knowing whether there's too little or too great an amount of that particular enzyme. And so DHT is much more potent than testosterone, and you should avoid excess amounts of that when there's the testosterone replacement therapy. And in fact, in cases like that, DHT should be reduced because you're getting too much of it via that 5-alpha reductase. And what do they do? Well, if men are suffering from male pattern baldness, quite often they take Proscar or Propecia, which is these are various drugs that you use for that. Well, one of the big, in fact, one of them is called finasteride. And what that does is it inhibits the 5-alpha reductase. Well, that's fine. But what it can do is create real problems for the levels of DHT. And so I'm not going to say more about that, except to say that that is one of the very important reasons for looking at it. Androstenediol is an important metabolite. It's an endogenous steroid hormone metabolite and neurosteroid. And I'm not going to say more about it right now, except to say that you need to look at that because of the issue of the high affinity for sex hormone binding globulins, similar to testosterone. And so if you're seeing very, very little active testosterone, you need to see why. The metabolites here, I'm not going to spend a lot of time on, except to say that there are, again, these metabolic pathways, such as androsterone and etiocolonelone. These are metabolites of testosterone, which again tell you about the enzymes that are producing these metabolites. In the case of, for example, AN, which is androsterone, that is produced by 5-alpha reductase. That's the one I talked about a moment ago. ET, the ETO, is not. That's 5-beta reductase. It's the 5-alpha reductase, which is the one that is extremely important. And why are we concentrating on this? Because a lot of people are also taking DHA supplements, and DHEA can often result in excess levels of androsterone or etiocolonelone, mostly etiocolonelone. And so 5-alpha reductase is going to be a way of being able to tell you if you have too much of one or the other, and how that is implicated by having taken too much DHEA supplementation. I'm not going to spend time on these other metabolites. They're really very minimal. I do want to spend a few moments on DHEA, because we all speak so much about DHEA, and remember that that is considered part of the androgen pathway, but is produced in the adrenal area. It affects bone density, is part of the stress response, as we know, involved in mood and cognition. And in fact, it's a very powerful element in autoimmunity. We also know that DHEA levels do begin to decline very quickly, actually, at the end of the second decade of life. DHEA also has a very marked first pass effect. That means if you give it orally, what happens is it gets degraded in the intestinal area and in the liver as well. So why is that important? Because that will be a determination in how DHEA is given, whether it's given orally or it's given in other ways. But remember, low levels of DHEA tell you that there are signs of adrenal stress, reduced androgen production. And if you have very high levels, that is seen with women who have polycystic problems, PCOS, or it can be a sign of oversupplementation. There's the 7-keto DHEA, which again is a metabolite which I'm not going to spend a lot of time on. Progesterone, we do not test in urine itself. What we do test for is its metabolite, which is pregnanediol, because progesterone does not enter into the urine in detectable levels. So when you're talking about progesterone, you're really looking at progesterone. But before we talk about that, here we go again. What are the variations of progesterone? Here's another one of hundreds of studies. 2018. And you look at the graph and you see serum progesterone during the mid-luteal phase, which, if you remember, is when progesterone has its highest levels. Look at this roller coaster ride for progesterone. Progesterone is released into the bloodstream in pulsations. That's why. So it's going to lead to very large fluctuations in serum progesterone. Not a big surprise. In fact, it can go up to eightfold in 90 minutes. So if anyone were taking something at the first minute of the 90 minutes with, let's say, dried urine, and then they were to look at it 60 minutes later, either with blood or with dried urine, they're going to get a totally different look at the levels of progesterone. In order to look at it reliably, you've got to look at it over a period of time, 24-hour, and in some cases, more than 24 hours for that matter. So bottom line, as Beckley here said in 2021, I chose one of the recent ones. I could have chosen one of hundreds. Single blood or urine test could be unreliable. So ideally, you test blood or urine over 24 hours or 2 to 3 days in a row to get the average. Again, it depends on what you're looking for. Why are we doing these tests? That's the key. So, as I said, progesterone is normally not excreted in the urine. It is the PD, which is the inactive progesterone metabolite, which quantitatively is the major progesterone metabolite. It's easily measured in urine. They're in large amounts, and that is the indirect measure of progesterone. And remember, it correlates very well, and this is important to know, it correlates very well with serum progesterone levels. So if you're looking at pregnenolone, you can be assured that that is very well related to serum progesterone levels. And it is important also to note that progesterone is much more stable than estrogen. So with all of its roller coaster levels, it will continue to do that over a number of days. Estrogens disappear within 24 hours, but progesterone will go on for a number of weeks. There is one last one, pregnenolone, which is metabolized indirectly from pregnenolone and progesterone. I mention it because it is important for these people who have congenital hyperplasia. And if you see levels, very high levels of pregnenolone, you do need to say to yourself, okay, I got this cheat sheet and I know I need to look at the possibility of congenital hyperplasia. Last but not least, let's look at the adrenal corticosteroid hormones. What we're talking about here is cortisol, cortisone, and their metabolites. And what we're looking for here are three main things. We want to look at the amount of free, meaning the active cortisol over 24 hours. We want to look at the relationship of the active cortisol to the inactive cortisone. And last but not least, we want to look at the metabolites, the metabolized cortisol, as a part of a total look at cortisol production. And so that's what we're going to look at for the last few minutes. And so here's cortisol, which is also given the letter F for free. And we know that free cortisol has a nice green reference age, and its whole reference is from 37 to 150 micrograms. It is the active fraction of the adrenal glucocorticoids. Now, what does that mean? Well, it really means that it just presents 2 or 3% of the total cortisol that's produced. So in blood, one of the reasons for not looking for it in blood is that blood will show you the total levels of cortisol, but most of them are attached to the proteins that I mentioned to you earlier, to sex-binding hormones, cortisol-binding hormones, and that'll bind up to about 97% of the cortisol. So there's only about 2 or 3% that is active, that is free, and that's what you pick up, not just in urine, by the way, but in saliva. And that's one of the reasons saliva is a wonderful place to pick up cortisol as well. Cortisol, for the record, has 2 primary actions and a third smaller one. The 2 primary ones is gluconeogenesis, that is the breakdown of proteins and fat that provides metabolites for the conversion to glucose in the liver. Very important. But the second one, which we're very familiar with normally, is it is a potent anti-inflammatory, extremely potent. And in that way, it does a number of things. It helps maintain blood pressure. It's a modulator of immune function. And it has a third minor action. It is a weak mineralocorticoid stimulator. So it stimulates levels of sodium, potassium, etc. So the measurement of free cortisol shows you if there's adequate active circulating cortisol. So that's number one. Now remember that cortisol is also in an inactive state, in a storage form in the body in general. You'll see that in the liver, and that's what it gets picked up in the urine. So in the liver, cortisone, which is the storage form, gets converted to cortisol when it's needed. And in the kidneys, it's just the opposite. Cortisol, which has now been used, has to get inactivated to cortisone. And that's a protective measure, by the way, since if you have elevated cortisol, that's going to activate the mineralocorticoid receptors. Remember, it has a minor function. As soon as it activates those receptors, what does it do? It brings up sodium reabsorption, decreases potassium secretion to keep it in the body, and that raises blood pressure. That's if cortisol is not inactivated. So you want to inactivate it, and that's what you do. And so the kidneys bring it into a cortisone level, and that's what you want to look for. So that's why the cortisone to cortisol ratio is important. And so cortisone measures adrenal reserve when you're comparing it to cortisol. And cortisol levels in the urine are normally about 30% higher than cortisol when both are in optimal levels. And that's important. There's another way of measuring it, and we're going to go through it in a moment, and that's to look not just at the primary hormones like cortisone and cortisol, but actually looking at their metabolites, which we're going to do in just a moment. And here we are. And these are the metabolites, these 17 hydroxysteroids, THEA, THEF, and the 5-alpha THEF. The THEF and 5-alpha come from cortisol, and you can see that here, whereas the HE is from cortisone. So moderately elevated metabolite levels with no elevation of cortisone or cortisol is observed in cases of mild adrenal stress. So someone is undergoing adrenal stress, and you're saying, well, wait a minute, their cortisone and cortisol levels are normal. Look at their metabolites, especially THE, which is going to be the first sign that something is amiss. So even when these primary hormones are at normal levels, it's not necessarily great. But the major importance of these metabolites is when you take the sum of the three of them, because that is important in looking at total endogenous cortisol production, because the sum of these three metabolites represents 50% of the total cortisol production in the body. So you need to know that. If you don't know that, you're missing a major component. So the reference levels for this are somewhere between anywhere from 1,000 to 6,000 or 3,000 to 6,000 micrograms a day. I'm looking at the sum. If the sum is greater than 6,000 or 7,000 a day, you're getting into red territory. And if you get into that territory, you need to consider the terrible things which we talk about: insulin resistance, metabolic syndrome, pre-diabetes or diabetes. And I know in previous lectures I've discussed this. This is a scourge on Western modern society, and you need to be aware of it so you can pick it up. In fact, all forms of hypercortisolism will lead to an upregulation, meaning an increase of the deactivating enzymes of cortisol and cortisol. Remember, I mentioned it, the 5-alpha or beta reductase enzyme, leading to an increased production of these metabolites. All of that is to say that this sum of the three metabolites is an important early detection method. And if the sum goes even greater, if it's way off the charts at 15,000 or more micrograms a day, that spells adrenal adenoma. And believe it or not, you can pick that up. There are some other metabolites, which are end products, which I'm not going to be discussing today. All of that is just to say that it's just another way of looking at whether the 5-alpha or 5-beta reductase enzymes are being up or down regulated. And there's one last part of the story, and that is the corticosteroids. Remember, I told you that in the adrenals, you also produce the corticosterones like aldosterone, which are important in controlling minerals, which are important for blood pressure. But they use the same enzymes as cortisol and cortisone. Again, 5-alpha and 5-beta reductase. So you need to know that, because together with DHEA and some of these other glucocorticoids in the adrenals, it is providing a comprehensive assessment of the overall adrenocortical health. And so, apart from a 24-hour comprehensive urine hormone profile, you can also do the plus. And what is the plus? Well, the plus is to look at diurnal cortisol. You cannot get a reproducible, reliable diurnal rhythm of cortisol if you're doing urine, 24-hour urine, or even dried urine, or frankly, ladies and gentlemen, if you're doing dried urine with 4 dried urine papers per day. You cannot get a good level at it. You really want to see what you see in saliva. So if you want to get diurnal cortisol, the way to do it, and this is established, it is the standard, is in saliva. And that's what we do when we do our salivary analysis at FDN. And if you want to look at that together with a 24-hour, you order the 24-hour comprehensive urine hormone profile plus, and it gives that to you. And what I'm going to be doing, both, as I said, in various broadcasts, as well as in consults and in a manual, is going to be looking at case studies. And you're going to see this kind of thing. You're going to see the actual report, as well as a discussion of all of the different elements that you need to know for an individual to take you through the case studies, and in that way to give you a good understanding of what are the important elements that you need to be aware of when you are doing a 24-hour hormone profile. And with that, I am going to say thank you.